Welcome to the Smarter CRC Patient Navigation Training Program. This is Video 1, Colorectal Cancer and Screening. My name is Jamie Thompson. I am a Senior Research Associate at the Kaiser Permanente Center for Health Research based in Portland, Oregon. In this video, we will talk about colorectal cancer and screening options. We will answer the following questions. What is the colon? What does it do? How does colorectal cancer begin? What are the stages of colorectal cancer and survival rates by stage? What are the warning signs of colorectal cancer? Who gets colorectal cancer and what are the risks? Who should get screened and how? Let's begin by talking about the colon and colorectal cancer. First, let's talk about the colon. This slide shows where the colon and the rectum are located. Both the colon and rectum are parts of the large intestine, which is part of the digestive system. The colon is the end portion of the gastrointestinal tract, which extends from the mouth to the anus. The colon is a muscular tube that is about 5 feet in length and about 2.5 inches in diameter. The main function of the colon is to eliminate wastes and toxins in the intestines, blood, and lymph system. What is colorectal cancer? Colorectal cancer occurs when cells in the colon or rectum become abnormal and grow very fast. It is the third most common cancer and the second leading cause of cancer deaths in the United States. An estimated 50% of colorectal cancer deaths could be prevented by screening and early detection. How does colorectal cancer begin? Colorectal cancer begins with a growth called a polyp. A polyp is a small growth of tissue that starts in the lining and grows into the center of the colon or rectum. Most polyps do not cause any harm. Most polyps will produce small amounts of blood that cannot be seen with the naked eye. Nevertheless, this blood can be found with a fecal test, which we will discuss later. About 6% of polyps become cancerous. Polyps are removed during a colonoscopy. The goal of screening is to find and remove polyps before they become colorectal cancer, or find colorectal cancer at an early stage when it is still treatable. You could think of your colon as a garden and polyps as weeds. During a colonoscopy, your doctor removes polyps before they become cancerous, just as a gardener would remove weeds before they overrun and destroy your garden. Once a polyp becomes cancerous, it grows over a period of 10 to 20 years and can be detected at different stages. This figure shows the stages of colorectal cancer. In the early stages, stage 0, 1, and 2, the abnormal cells in the colon or rectum can be removed before the cancer has formed in the wall of the colon or rectum. In stage 3, the cancer has spread to the lymph nodes. Lymph nodes are these bean-shaped structures that help fight infections. In stage 4, the cancer has spread to other organs of the body. When cancer occurs in other organs, it is said to have metastasized. Each advancing stage of colorectal cancer is associated with a smaller chance of surviving 5 years. Let's look at the survival rates more closely. In stage 1, the cancer is in the inner layers of the colon or rectum, surrounded by normal tissue, and there's an 80 to 90% survival rate. In stage 2, the cancer has spread through the muscle wall of the colon or rectum, but has not breached it, and there is a 50 to 80% survival rate. In stage 3, the cancer has spread to nearby lymph nodes, and there is a 40% survival rate. In stage 4, the cancer has spread to other areas in the body, and there is a 10% survival rate. In general, chances of survival are high in the early stages. Here's another way of looking at this information. Approximately 9 out of 10 individuals diagnosed with early stage colorectal cancer that has not spread beyond the colon or rectum survive 5 years, and many live much longer. However, only approximately 1 out of 10 individuals with advanced stage colorectal cancer that has spread to other organs, such as the lungs or the liver, will survive 5 years. So it's very important to find colorectal cancer early. The warning signs of colorectal cancer include changes in bowel habits, such as having diarrhea or constipation or narrowing of the stool. Growths in the colon or rectum can restrict the transport of waste, resulting in narrow stools. There could be a constant need to have a bowel movement, or blood in the stool, which may appear dark, or low blood counts, also known as anemia. The dark stools may result from blood produced by the polyps or tumors. Other warning signs include weakness and fatigue, cramping or abdominal pain, and unexplained weight loss. In this section, we will talk about who gets colorectal cancer. In general, colorectal cancer occurs in both men and women. Age is a primary risk factor, along with family and medical history. Finally, diet and exercise are also factors. We'll talk more about each of these factors on the upcoming slides. Let's start by talking about age. Age is an important risk factor for colorectal cancer. The vast majority, over 90% of colorectal cancers occur in adults over the age of 50, which is the age that screening is recommended for adults who are at average risk. Another factor is medical history, such as having a family member with colorectal cancer or having colon disease. On this slide, we will review various medical history factors. Here's the first bullet. You can interpret this information as an individual with more than one relative with colorectal cancer has a probability of getting colorectal cancer that is 4 times greater than an individual with no medical history. An individual with a relative who was diagnosed with colorectal cancer before age 45 has a probability of getting colorectal cancer that is 3.9 times greater than an individual with no medical history. An individual with one first-degree relative with colorectal cancer has a probability of getting colorectal cancer that is 2.2 times greater than an individual with no medical history. A first-degree relative is a person's biological parent, full sibling, or biological child. An individual with inflammatory bowel disease has a probability of getting colorectal cancer that is 1.7 times greater than an individual with no medical history. Finally, an individual with diabetes has a probability of getting colorectal cancer that is 1.3 times greater than an individual with no medical history. Let's also look at behavioral factors. Eating red or processed meat, consuming alcohol, leading a sedentary lifestyle, and smoking are all linked to higher risk of colorectal cancer. Factors that reduce your risk include exercise and physical activity, and fruit, vegetable, and fiber consumption. Finally, colorectal cancer occurs more commonly in men than in women and is more common in African Americans than other racial groups. 1 in 20 people in the United States will develop colorectal cancer in their lifetime. This means the lifetime risk is 5%. This amounts to about 140,000 new cases each year, or 16 new cases each hour. As mentioned earlier, colorectal cancer is the second leading cause of cancer death in the US. About 50,000 people in the US will die from colorectal cancer this year. The good news is that regular screening could prevent at least 60% of these deaths. It's important to remember that most early cancers will have no noticeable symptoms because polyps may form before there are symptoms. The screening is needed before symptoms occur. Currently, 28 million people in the US are not up to date with their colorectal cancer screening recommendations. So let's spend a little bit of time talking about colorectal cancer screening. As a reminder, the goal of screening is to find and remove polyps before they become cancer or find cancer at an early stage when it is treatable. In this section, we will talk about who should get screened, what are the screening options. Who should get screened? Colorectal cancer screening is recommended for average risk individuals beginning at age 50. Some people are considered at increased risk for colorectal cancer. These individuals may have a personal history of colorectal cancer, large polyps, or colon disease. These individuals may have a strong family history of colorectal cancer or polyps. Or these individuals may have a known family history of a hereditary colorectal cancer syndrome that puts them at especially high risk of colon cancer, for example, Lynch syndrome. Finally, patients at an increased risk need to get a colonoscopy, not a FIT, on a schedule determined by their GI doctor. There are several ways to screen for colorectal cancer, and there are advantages and disadvantages for each test. The most commonly used tests are fecal testing and the colonoscopy. Let's start by talking about fecal testing, also known as FIT testing. A FIT test looks for hidden blood in the stool. Blood is the blood that is produced from a polyp or colon cancer. A FIT test is easy to do. It is a simple test that can be completed at home. It is low cost, but it is needed every year. And a colonoscopy would still be needed if the findings were abnormal. Some commonly used FIT tests are Ensure 1 and OC Micro. Second, a colonoscopy allows the doctor to see the entire colon. The GI doctor or the gastroenterologist inserts a tube into the rectum to view the colon. The procedure allows the doctor to examine the entire colon and detect and remove any polyps. It also requires that patients prepare for the colonoscopy by not eating and taking a laxative the day before the appointment. In addition, patients need a ride to and from the medical facility, as well as a companion to accompany them. However, the colonoscopy is only needed every 10 years if the results are normal. Other tests, which are not as commonly used, include sigmoidoscopy, which examines the lower colon only, CT colonography, this is an x ray of the colon, and then stool DNA or FIT DNA, which detects blood and DNA in the stool. An example of this test is Cologuard. For both the CT colonography and stool DNA test, a colonoscopy would be needed if the test is abnormal. Some of these tests may be more expensive, cannot be reimbursed, or are not routinely done by the health systems. Most clinics promote the use of the FIT. And if you're curious which test is the most effective when you compare the FIT versus the colonoscopy, they are similar in effectiveness as long as patients follow the recommended screening intervals. And remember, the best test for your patient is the one that gets done. So to review, what is the colon and what does it do? The colon and the rectum are the end portion of the digestive tract. The colon is a muscular tube that is about 5 feet long by 2.5 inches in diameter. The colon and rectum remove waste from your digestive tract, blood, and lymph system. How does colorectal cancer begin? Colorectal cancer starts as a polyp, a small growth in the lining of the colon or rectum. What are the stages of colorectal cancer and survival rates by stage? There are 4 stages of colorectal cancer. In general, the chances of survival are high in the early stages. Stage 1 cancers have a 90% survival rate versus stage 4 cancers that have a 10% survival rate. Screening that removes polyps can prevent cancer from occurring. What are the warning signs of colorectal cancer? There are several symptoms of colorectal cancer, including changes in bowel habits, fatigue, and anemia. However, screening is important before symptoms occur. Who gets colorectal cancer and what are the risks? Men versus women and African Americans versus whites are at higher risk. Age, medical history, and diet are also risk factors. Who should get screened and how? There are several screening options and they vary in their costs and how often they need to be done. Many initial tests require a follow-up colonoscopy. The best test is the one that gets done. This concludes video 1, colorectal cancer and screening. Thank you for watching. For more training videos, please visit a to be determined website.